I, Dr. Anup Kumar, I will discuss today about pediatric pneumonia. Pneumonia is the leading cause of death in children worldwide. The most common cause of death in under 5 child. What is pneumonia? Pneumonia is acute infection of the parenchyma. The term lower respiratory tract infection include pneumonia, bronchiolitis, and bronchitis. Bronchopneumonia is the patchy consolidation involving one or more lobes, usually involves the dependent lung zones. Miliary pneumonia is the term applied to multiple discrete lesions resulting from a spread of pathogen to lung via bloodstream. Interstitial pneumonia is patchy or diffuse inflammation involving the interstitium characterized by infiltration of lymphocytes and macrophages. In alveoli, there is protein-rich hyaline membranes and it lines alveolar spaces. Congenital pneumonia present within 24 hours after birth. Pneumonia may originate in the lung and may be due to focal complication of contiguous systemic inflammatory process. Etiology of pneumonia. In viral etiology, RSV, influenza, parainfluenza, adenovirus is present in 40% of patients. In 2/3 bacterial etiology there. Common bacterial agents first 2 months is gram-negative agents like Klebsiella pneumoniae or E. coli, gram-positive agonine, pneumococcus, staphylococcus. Between 3 months to 3 years, agents are pneumococcus, H. influenzae, and staphylococcus. After 3 years, most common is pneumococcus and staphylococci. In adolescent and older children more than 5 years, chlamydia and Mycoplasma may also cause community-acquired pneumonia. Gram-negative organism usually causes pneumonia in early infancy and severe malnutrition in immunocompromised children also. Pneumocystis jirovecii and histoplasma can cause pneumonia in immunocompromised children like HIV, and in 1/3 of children causes may not be known. These are the detailed list of causative pathogens age group wise. Here also 2 to 5 years and 5 to 18 years. Above 5 years, Mycoplasma is the most common cause. Pneumonia history and fundamentals. We have to take history properly, and the age groups like pain-type symptom, fever is there, or high grade fever is there or not, recent upper respiratory infection, associated symptoms like headache, lethargic, viral symptoms, diarrhea, like rash, and what is the duration of symptoms. We have to ask for immunization status, TB exposure, contact with ill people, travel history, past medical history, birth history. For definition of pneumonia, respiratory rate is the most important cutoff, and less than 2 months more than 60 is respiratory rate, 2 to 12 months more than 50 rate, 12 months to 5 years more than 40, and greater than 5 years more than 20 respiratory rate is there. It is called pneumonia. And indication of severe infection, if in infancy more than 70 rate, and 1 to 5 years more than 50 rates indicates severe infection and requires hospitalization. We have to look for chest in drying, lower chest wall in drying with inspiration, lower chest wall moves in, and other side is nasal flaring with inspiration, side of nostrils flared outward. Diagnosis in community setting. We have to look for tachypnea and respiratory distress, because respiratory distress and tachypnea are the most important signs of the pneumonia. If there is lower chest in drying with tachypnea and a stridor in calm child, it is known as severe pneumonia. We have to refer urgently to the hospital and give injectable antibiotics and oxygen if needed, first dose of appropriate antibiotic. If there is tachypnea it is known as non-severe pneumonia. Normal respiratory tests may be other causes of respiratory illness. In case of pneumonia, prescribe appropriate antibiotics, advise caregiver of other supportive measures, and when to return to follow-up. Infants less than 3 months are higher risk for pneumonia and should be referred for immediately for hospitalization because high risk of this severe illness and death. Infants who are premature with congenital heart disease or cooling heart disease are increased risk of. Clinical feature: bacterial pneumonia in less than 3 years should be considered when the fever is more than 38.5 degree and chest recession is there and respiratory rate is more than 50. Older children, history of difficulty in breathing is more helpful than clinical sign. If wheezing is present in preschool child, primary bacterial pneumonia is unlikely. We have to differentiate between bacterial LRTI and viral LRTI. Fever more than 38.5 degree and respiratory rate more than 50. Chest recession, wheezing. Wheezing not present in bacterial pneumonia, but in viral pneumonia it occurs in infant and young children. Wheezing is there, fever less than 38.5, and there is marked recession, hyperinflation of chest. Radiograph shows the hyperinflation, maybe patchy collapse, maybe 25% also there. In bacterial pneumonia, there will be consolidation rather than collapse. Radiological investigation: chest radiography should not be routinely done in uncomplicated acute lower respiratory infection, and the radiographic findings are poor indicators of etiology. Follow-up of chest radiography should be only performed if lower collapse or there is continuing symptom. Imaging: bacterial pneumonia, there is lobar consolidation, round pneumonia with pleural effusion. Viral pneumonia, there is castrically shows diffuse sticky infiltrates of bronchopneumonia. Atypical pneumonia, there is increase in interstitial marking or bronchopneumonia. Chest X-ray should be done if infection is severe, diagnosis is otherwise inconclusive. If there is shortness of breath, to exclude other causal foreign body heart failure. Look for complication pneumonia unresponsive to treatment like empyema, pleural effusion, and less than 3 months with fever, we have to do X-ray to rule out pneumonia. There is right upper lobe pneumonia. Here is right middle lobe pneumonia. Laboratory test: in uncomplicated LRTI, no need for routine blood test, but we have to consider test if there is a complication or higher fever. CBC count, electrolytes, particularly sodium, blood culture, sputum culture, HIV, HTV testing required. WC count in viral immunities is usually normal or mildly elevated with predominance of lymphocyte. Bacterial pneumonia, WC count is elevated with predominance of neutrophils. In Chlamydia trachomatis pneumonia, there is mild eosinophilia. General investigation pulse oximetry should be done in every child. Acute phase reactant usually do not distinguish between bacterial and viral infection. Blood culture should be sent in all suspected bacterial pneumonia. With viral pneumonia, the nasopharyngeal aspirate should be sent for viral antigen detection with without culture. If there is fluid present, we should tap it for diagnostic purposes, microscopy examination and culture, and look for a bacterial antigen. Indication for hospitalization of the child with pneumonia: if caregiver are unable to care for the child, and then child should be admitted to healthcare facility. If child is less than 3 months of age, failure of outpatient treatment, worsening, no response to treatment after 48 to 72 hours, family lives in remote area, is the indication for admission as per AIIMS. All children with very severe pneumonia needs admission. Very severe pneumonia include cough or difficulty in breathing plus at least one of the following: central cyanosis, inability to breastfeed or drink or vomit everything, convulsion, lethargy, unconsciousness, severe respiratory distress like head nodding, some other signs of pneumonia, tachypnea, grunting, nasal flare, in drying, changes in auscultation. Inpatient management. Consideration must be given to provision of adequate hydration, oxygenation, nutrition, antibiotics, and pain control. Monitoring should include respiratory rate, work of breathing, temperature, heart rate, oxygen saturation, finding on auscultation. Indicators for admission to hospital in infants is the oxygen saturation less than 92%, or cyanosis, respiratory rate more than 70, difficulty in breathing, intermittent apnea, grunting, not feeding well, family not able to provide appropriate observation or supervision. In older children, indication are oxygen saturation less than 92%, respiratory rate more than 50, difficulty in breathing, grunting, signs of dehydration, family not able to provide appropriate observation or supervision. Streptococcus pneumoniae, the most common cause of pneumonia, both overall and death-wise, and antibiotic resistance also developed worldwide. Incidence is higher in less than 2 year of age and more than 65 years of age. Penicillin was the drug of choice, but now there is resistance to ceftriaxone, ceftriaxone, the first line drug. Signs: sudden onset of chills and pleuritic chest pain, followed by fever, then cough for active rusty sputum. And respiratory tract symptom may be initially absent, and lack of fever not uncommon, indicate poor prognosis. Gastro symptom: nausea, vomiting, diarrhea may be present, 15 to 25%. The bacteremia may be there in 20 to 25% cases. More frequently have chills, gastrointestinal symptoms, but less often myalgia and respiratory symptoms. X-ray shows pulmonary infiltrate are alveolar in nature, most involving one or more segments within a single lobe. Lobar consolidation air bronchogram present only in minority of cases, but most frequently with patients with bacteremia. Pleural effusion, the common finding, whereas complicating like empyema is seen very rarely. Complication were empyema, pulmonary abscess, endocarditis, and meningitis. Staphylococcus pneumonia usually may be primary pneumonia and may be due to complication of streptococcal septicemia, and maybe complication of measles, influenza, or cystic fibrosis, or follow Staphylococcus pyoderma. Debilitating conditions include malnutrition, diabetes mellitus, macrophage dysfunction, are also predisposed to infection with staphylococci. Pneumatoceles, if are present, they are pathognomic of staphylococcal pneumonia. Usually there is alveolar microabscesses are formed and gradually develops into lung abscess. And many times lung abscess rupture into pericardium, leading to purulent pericarditis. If empyema is there below 2 years of age, it is most probably a staphylococcal cause. If there is disseminated staphylococcal infection, then pneumonia is present, then this pneumonia is staphylococcal pneumonia. And if there is complication like pneumothorax and pericarditis is there, is highly suggestive of staphylococcal pneumonia. In causes of atypical pneumonia, Mycoplasma pneumoniae and Chlamydia pneumoniae are the most common. Incidence varies between 1.5% to 33%, and 33% have evidence of Mycoplasma pneumonia out of 203 children. 40% have acute presentation, 60% have gradual presentation, 90% have lower changes also. In less than 5 years, Streptococcus pneumonia is more common than Mycoplasma pneumonia, but above 5 to 15 years, Mycoplasma pneumonia is more common than Streptococcus pneumonia. Mycoplasma pneumonia occurs in school children. Cough, wheeze, and pneumonia is there. Interstitial infiltrate. There may be lower consolidation and higher adenopathy. General management. Child care for at home should be reviewed by general practitioner if deteriorating, if not improving, after 48 hours on treatment. Patients whose oxygen saturation is 92% or less while breathing air should be treated with oxygen given by nasal cannulae, head box, face mask to maintain oxygen saturation above 92%. Nasogastric tubes may interfere with breathing, should be avoided in severely ill patients. Children, especially with infants who have very small nasal passages, if be used, then a smallest tube should be used. Intravenous fluids, if needed, should be given at 80% vessel and serum electrolytes monitored. Chest phase therapy is not beneficial. Antibiotics and analgesic can be used to keep child comfortable and to help coughing. In the ill child, minimal handling should be done to reduce metabolic and oxygen requirements. Patient on oxygen therapy should at least 4-hour evaluation including oxygen saturation. Indications for transfer to intensive care. Patient is failing to maintain NSP2 more than 10 to 2%, in FI2 of more than 0.6 and 60% FI2. If there is shock, recurrent apnea or slow or irregular breathing, rising respiratory rate and rising pulse rate with clinical evidence of severe respiratory distress and exhaustion with or without rate arterial carbon dioxide tension. Complication and failure to improve. If child remains paraxial, fever persisting or unwell after 48 hours admission, re-evaluation is necessary. And we have to ask some questions. Is the patient having appropriate drug treatment on adequate dosage? Is there lung complication of pneumonia, such as collection of pleural fluid, development of empyema, or evidence of lung abscess? Another thing is due to host immunosuppression, and host child is not responding due to immunosuppression. Case of pneumonia, pleural effusion, there is accumulation of fluid in pleural space, result of inflammation. Empyema, there is bacterial infection in the pleural space leading to accumulation of pus. Parapneumonic effusion develop in approximately 40% of patients admitted to hospital with bacterial pneumonia, but it usually resolves with IV antibiotic or proper IV treatment. If effusion is present and the patient is persistently febrile, then empyema should be suspected and pleural space should be drained. Necrotizing pneumonia, necrosis or liquefaction of lung parenchyma, lung abscess, collection of inflammatory cells leading to tissue destruction resulting in one or more cavities in the lung. It is rare complication, and treatment of both requires long-term parenteral antibiotic for 2 to 4 weeks or 2 weeks after patient is afebrile and has clinically improved. Pneumotocele, thin-walled air-filled cyst of the lung, often occurs with empyema Pneumatocysts often resolve spontaneously with treatment, but may lead to thorax. Another complication is hyponatremia occurs due to SIADS, and it is associated with more complication and increased mortality. Complication of specific infection. I already told Staph aureus leads to pneumococcal, may cause pneumothorax and Mycoplasma pneumonia. Causes complication is almost every body system. Rashes, Stevens-Johnson syndrome, hemolytic anemia, polyarthritis, pancreatitis, hepatitis, pericarditis, myocarditis, neurological complications, encephalitis, aseptic meningitis, transverse myelitis, acute psychosis have been reported. Treatment. In treatment of pneumonia, first we have to treat as ABC, airway, breathing, circulation, then provide oxygen, and we have to go with an IV antibiotic, and if there is presumed bacterial pneumonia, amoxicillin or amoxicillin carbonic acid should be given. If there is presumed atypical pneumonia, azithromycin or oral clarithromycin or azithromycin can be given. Community-acquired pneumonia in child more than 5-year-old. Presumed bacterial pneumonia, we have to give oral amoxicillin, or we can add macrolide also. Alternative are amoxicillin carbonic acid. In presumed atypical pneumonia, oral azithromycin 10 mg per kg per day for 5 days should be given. Alternatives are clarithromycin and azithromycin. If child is more than 7-year-old, doxycycline can be given. Management of inpatient community-acquired pneumonia in all ages. There is presumed bacterial pneumonia, ampicillin or penicillin G can be given, but there are reporting of resistance. So we should start with ceftriaxone, cefotaxime, and with addition of vancomycin or clindamycin if there is suspected community-acquired MRSA. And inpatient community-acquired pneumonia, presumed atypical pneumonia, azithromycin in addition to beta-lactam should be given. In community-acquired pneumonia who are not completely immunized, presumed bacterial pneumonia, ceftriaxone or cefotaxime, addition of vancomycin or clindamycin for suspected community-acquired MRSA. Alternatives are levofloxacin, vancomycin or clindamycin. Management of community-acquired pneumonia not completely immunized. We suspect presumed atypical pneumonia, then azithromycin in addition to beta-lactam if diagnosis in doubt. Alternatives are clarithromycin, azithromycin, doxycycline, levofloxacin. Management of community-acquired pneumonia, Streptococcus pneumoniae who are highly resistant, and for parenteral therapy preferred is ceftriaxone and 100 mg per kg per day. Alternatives are ampicillin, levofloxacin, linezolid, clindamycin or vancomycin. Management of community-acquired pneumonia with Mycoplasma pneumoniae for parenteral therapy, intravenous azithromycin 10 mg per kg per day. Transition to oral therapy later should be given. Treatment of severe community-acquired bacterial pneumonia, suspected MRSA, treatment should be given. Vancomycin or linezolid should be used. Empiric antibiotics for treatment of severe pneumonia. Moderately severe non-ICU pneumonia, erythromycin, doxycycline plus ceftriaxone or cefotaxime. Complicated pneumonia, abscess, effusion or severely ill patients requiring ICU admission. In that case, ceftriaxone or cefotaxime plus vancomycin or clindamycin plus azithromycin should be used. Duration of therapy in pediatric pneumonia. We have to start with parenteral, usually preferred, and we have to later switch over to oral. If a child is afebrile for 24 to 48 hours, and child can take orally. In uncomplicated cases, total duration is 7 to 10 days. In complicated cases like necrotizing pneumonia abscess, around 4 weeks of IV total antibiotics are required. Interventions to protect against pneumonia: hand washing combined with improved water and sanitation. We have to promote exclusive breastfeeding for 6 months. It leads to decreased incidence of pneumonia. Adequate nutrition throughout the first 5 years of life, including adequate micronutrient intake. With adequate complementary feeding, reduces the child death with pneumonia, and we should target to reduce incidence of LBW, low birth weight babies. Preventive strategies: vaccination against measles, Streptococcus pneumoniae, H. influenzae type B. Public awareness, intervention to protect against pneumonia, zinc supplementation, prevention of HIV in children, cotrimoxazole prophylaxis for HIV infected children. Nowadays, vaccines for many bacterial pathogens are available, like Haemophilus influenza type B vaccine, pneumococcal conjugate vaccine, and another one is the measles, and prevention of measles decreases incidence of pneumonia. And half of the severe cases of pneumonia among children in developing countries are caused by pathogens that can be stopped by vaccines. Reducing indoor air pollution by changing to cleaner gas or liquid fuels, and it leads to decreased incidence of pneumonia by 22 to 46%. Thank you.